que vamos a iniciar.
I think we should start.
Bueno, muy buenas tardes.
Right, good afternoon to all people that today are accompanying here from the different places of the country and of Latin America. Also, thank you very much to the guest speakers who are going to share with us today valuable experiences that we have called Innovation in Human Health and Primary Healthcare. This is the 10th webinar that we have of this innovative bundle, an initiative, a special initiative that we have from Salud Derecho and Ethnic Lab. So we have the facilitator team from the World Bank. This webinar is being transmitted directly through the YouTube channel in Salud Derecho, and the session is going to be recorded for academic purposes, and it may be queried in the website at www.saludderecho.net. There you can find all the other videos of the sessions that we have carried out. Microphones are being disabled. I request that you keep your cameras turned off, and in the Q&A section that you have at the bottom bar to do the question there and through the chat. Today, we also have available the simultaneous translation services to English. At the bottom of the screen, you have this little globe, the interpretation where, so that those who wish to have translation can listen to it in English. Right, without further ado, and for the topic that summons us here today, the mental health affects the well-being of people and of families that suffer mental health, and sometimes they lead to discrepancies, and it also means a high financial burden. And according to data of the mental health, 1 out of 8 people has one type of some sort of mental health, and these are the main causes of disability, and it's responsible 1 of every 6 years that they have lived with disability, according to the World Health Organization. However, we know that there are certain deficiencies that you have in the way mental health is being tackled by the health sector, and in particularly how they're being serviced from primary health care, how they're being paid attention to. We're going to have 3 valuable and beautiful experiences and become led by organizations of NGOs that have worked with academia. These experiences have innovative elements that have to do here of the mental health, and it is very disprotected and so on. And we also have today strategies to facilitate the diagnosis and the timely ones of the changes that we have that frequently we detect in primary care. Precisely this about this topic, and this is what we're going to have our first guest, who is a psychiatrist and a master's in psychosocial research of the Andes University and with doctorate studies in mental health in Chester University.
En docencia y en investigación.
Experience in teaching and research. Paola is a representative for Latin America of the tool of mental health assessment globally in primary healthcare, and she is certified as a teacher NHK, and she's a professor of the medical faculty of El Bosque University in Bogota. Dr. Tejada, she's going to talk about the skills for diagnosing and handling mental health in primary healthcare. Welcome, Dr. Paola. We're going to see how's your sound, audio, and welcome, Paola. Thank you very much. Well, good afternoon to all the people who are here with us. Please confirm if you're hearing me well. Yes, we hear you well, and we're seeing you. I am about to ask that those who have the camera turned on, please close it, and we only leave the camera of Dr. Paola. Yes, thank you very much. Yes. And then Dr. Paola said, yes, do you have, are you seeing theirs? I seeing you. Yes, yes. No, the presentation, yeah.
¿Ahora?
Ahora ya puedes ponerla en
Yes,
presentación.
now you're not being shared.
Adelante.
Yes. Perfect. Well, thank you very much. Good afternoon to all. And effectively, as the title of my presentation says, I would like to talk about the skills to diagnose and to handle primary health care in health. And this graph here that I'm showing here, this is what I usually use in my classes because I think that it draws perfectly the difficulties that we may find, as well as showing us the possible solutions. So let's just see that if in the first bar we have the people with depression in general population, we're going to start with 100% of those that have depression end up requesting a health support, a GP or something like that, between 60 and 70%. So we see that there is a percentage of people that never comes to the health system. But once again, but we do have an important group of people that happens. But how many of these that actually go to medical medicine end up really receiving a depression diagnosis? And here now we're going to 30 to 35%. Of those, how many receive the treatment, the adequate treatment? 9%. And of those, how many 3 months later stick to the treatment? It's like 4%. So look, these graphs, we can interpret them in a very negative or positive way. I mean, half full the glass of half empty. So negative, look at the difficulties of diagnosing as well as treating in our health services, and makes it that people really don't end up receiving the adequate attention. But as I was telling you, this actually sheds some light as to what could be the possible interventions. I mean, look, that we, if we were to improve the diagnosis capabilities of those GPs and the capacity to orient them to have timely services, we would be covering an important set of people without a specific diagnosis, in this case, depression, although perfectly this can happen with many of them in mental health. And why does this happen in this graph? Well, literature has been ample publishment, and it's because there's a lack of knowledge about the diagnosis criteria, different in mental health, different to the other areas of health. We don't have paraclinical or medical or lab tests that says, oh, this person has anxiety or has depression or schizophrenia. The criteria and the ways of getting to the diagnosis is actually clinical. And many a time, these criteria can be something cumbersome for those who don't handle it every day. It's just a five a greater, and then it's 2 weeks, and then the other ones you have a positive system, and you have to fulfill the A and the B. That can be a bit complicated. Second is the lack of familiarity with the proper question to actually assess the mental state. Well, I could say that a person with depression, you have to control the suicide risk, but how do I ask a person if they want to die or not? It's important to ask if the person has hallucinations on this, but how do you ask a person if you're hallucinating? How do I tell a person if you have a a feeding alteration? The other reason for which we focus very much on the diagnosis and the treatment, while we know it, time constraints, clinical constraints with many patients where we don't have enough time to do assessments, especially if we have the idea that mental health, I need to sit down an hour with one person to do a full interview. And then, of course, in my environment with so many patients every 15, every 20 minutes, I cannot do that. And then an important reason is we have many players in the health sector that think that it is not their duty to do this assessment, this evaluation. There are some people that consider that mental health is a psychological and psychiatric matter, and all other doctors should not find out or intervene at that level. What is the reality? We've seen that the great majority of people with mental health, their first contact is going to be with primary health care, or non-specialized care. That is a reality. That's what end up, and that is why it is so important to have these strategies that help people who are at those levels of care, that are able to identify all those people that have mental health problems, and to start some appropriate management manner to see who or which can be cared for in a first level and who will possibly need the intervention of a specialist. And there are several strategies that have been proposed pursuant to helping solve these problems. And I'm going to talk about two that have not only the sufficient evidence about their usefulness, but also because I have worked with them directly and I can shed some light in that respect. The first strategy of which I wish to talk is about the depression, is the MH gap. And let me go back a bit of the story as to where did this comes up. There was a study once pursuant to seeing in different countries of the world how are the gaps in mental health. And understanding a gap is the people who have mental health problems and the number of people that in the end received it, how many were left outside. Countries with great health systems had gaps of about 20%. In other words, there were 20% of people who had mental health problems did not receive the proper care. But there were countries, for example, certain countries in Africa whose gaps got to be of 90% to 95%. And that is why the World Health Organization creates the program of closing the gaps, the image gap, for its initials in English to close these mental gaps. And you have a guide of intervention, the NH gap, for consumption alterations or mental health alterations for non-specialized people. In this guide, we are in the second version. So how does the guide actually work? The first thing, the guide is a downloadable, and although we have the physical presentation, generally the physical presentation, we have the training, but any person can actually go to the PAHO and you could download it, and you can now download it for an app uh, and a table. And then the guide prioritizes a whole series of problems of mental health, which are these depression, psychosis, epilepsy, mental alterations among children and adolescent teenagers, dementia, disorders due to substance abuse, suicide, self harm, and other significant mental health complaints. And how does this work? I can give them to any of these problems, for example, depression, and the guide begins to show me an algorithm initially of assessment. And then it says here, what are the manifestations? The common manifestation of depression. Is the person depressed? I'm actually to see what are the key symptoms. And they say no, yes. And in the measure that actually say yes to each one of the questions posed, let's just say that the guide takes us to the end where we have the most probable diagnosis that the person has that I am assessing. Aside from having an entire diagnosis map, the guide what has what I like the most, and they're the handling sort of flyers where we have some protocols for the diagnosis, and these protocols clearly are differentiated according to the psychosocial interventions, and then we have pharmacological treatment interventions should it be necessary, and then social ones according to the special functions. So, for example, when you have teenagers or children or women during pregnancy and while breastfeeding. So, currently the image gap, well, and we know that their origin is in the World Health Organization. It's been applied to more than 90 countries, has been used. The strategy is used in more than 20 languages. But here is actually very important to clarify something. And although if I said that if I told you the guide was actually available to be downloaded and maybe used by whom wishes to use it, let's just say that that is part of the invitation. Since we're talking about a strategy, this strategy goes over and beyond just to have a guide in hand. This is why we recommend that the guide is accompanied by two phases that are very important: training and supervision. Training and the guide should be carried out by trained people as trainers of MH gap. And once they have the formation of the MH gap or the training for the MH gap, the second phase is that you go and supervise its implementation. So, in other words, we're seeing that effectively the guide is being used in the field and to make sure that if there were any doubts in the middle, we would change. Currently, the follow-up and the implementation is available due to the petition of the ministry, and the PAHO can actually request this directly or in certain secretaries of health. So, for example, the Secretary of Health of Bogota, the municipality's Secretary of Health, you can request some training of venues. Now, each strategy of which I wish to speak, which is the Global Mental Health Assessment Tool, this is a clinical one, so it's semi-structured and computerized to assess and identify the mental ones that are there. And then we have there uh, that are not specialized. So how does it work? This tool, this one, assess it for 20 types of mental health problems. And here in this slide, we actually could mention what anxiety, depression, suicide risk, sleep, appetite, psychotic system, consumer of alcohol and hallucinogenic substances. And this is performed in a relatively brief time. It's like 15 minutes or less. So I'll let you know how does it work. And let's just say that it's a tool that it's relatively easy to use. So this tool is actually free there, and then we have there to be downloaded in a computer or in a mobile phone, Android, and it works as follows. I mean, you have here like certain windows with a with a particular symptom, in this case, worries, for example, and then the ages, and the interview begin. You give these questions to the person who's going to be interviewed. If you're very concerned, what are the things that make you lose sleep? Are you worried about money, family problems, etc., etc.? And the idea is that the interviewer, based on the answers received, they actually can detect the presence or absence of that system and how severe it is. And what this program does is that it has an internal algorithm that, based on the answers that I am giving and how I'm feeding the person, this system is going to gear me towards more questions about certain topic in particular, or it begins to speak about other mental health issue at the end of the interview and the program. You create a printable document where you have all the information that we have gathered from the patient, the systems that we have had in the interview with the severity of each, and after ending, based on what he learned before, and to have the possibility that the presenter has the clinical criteria to to determine what's going on. And this image help gap was created in the UK. That's why its original language is in English, but currently it's available in many other languages, including Spanish, and in particular in the validation in Spanish of the tool, and actually of localizing, we have validated in Colombia in our context. Likewise, what we have like with the MH gap, with the GM get, although it's downloading is free and any person can actually use it without any problem. As part of a strategy that is more thorough, we suggest that we do the full training in Zoom. It is important to clarify that. Well, fine. I have actually spoken about two strategies. Of course, there are many more available, but when we're speaking about the strategies, the idea is not to put one strategy against another or at the end of the day, they'd say, "Oh, this one is better than the other." For my experience, actually, you say that these two that I just mentioned, they actually complement them quite well. I don't know if you saw the GM head has more diagnosis, and let's just say that it's a bit easier to use, so that the same program is the one that actually takes me through the sort of diagnosis and roadmap. But then the MH gap is actually has a great module for adolescents and children, and they have intervention on how to handle them after you detect something. It's actually very useful. So in conclusion, what I wanted to show you today, that first there is an urgent need so that the professionals are not qualified over there. There's sometimes some people who are not necessarily health professionals, and that they may have skills to detect.
Se nos cayó la señal de la doctora Paola.
Sí, ya la estoy llamando de nuevo.
Ok. Excelentes herramientas las que está presentando. A ver, doctora Paola, tuvimos una interrupción de su exposición. Estaba ya en la última diapositiva. Si quiere retomarla, la última. Gracias.
All right, if we can retake the last one. Look, basically, what I was saying is that in what we all agree is that it's really very important that we find what are the best strategies that can help both the health personnel who are not specialized and even people outside the mental health, but that who should have the capacity to detect, handle, and follow up to those people who have problems of mental health. And so far, the evidence, not only of these strategies that I'm showing you, but many others, they show us that it is possible to train in relatively a short span of time so that they have an agreement in the knowledge of the basis that they may have, the people who have any contact with a possible problem in their mental health. So, thank you very much. And this is what I wanted to show for today for you.
Muchísimas gracias, doctora Paola.
Thank you, Dr. Paola. Thank you very much. Very interesting. The tools that you have just put available freely for the use of health professionals and caregivers that very probably can have mental health problems. Thank you very much. And now I'm going to ask if you could please in the chat, you could put the electronic addresses where these tools are now available so that whomever are participated in the webinar can take the address and they may investigate or research directly with the tools and about the technical assistant work for the use of the tools. Thank you very much. And I invite you to remain with us for the panel. And those who are participating there, they can put their question, whether in the chat, in the Q&A, as well as the other chat. Now we're going to receive Natalia Quiñones. She accompanies us from Italy with 6 or 7 hours, 6 hours of difference. Thank you very much for accepting to participate here and to make this effort. I know it's getting late for you. I know where you have there of primary health for group migrants is going to leave us with very inspiring results in building peace. And Natalia is a co-founder and director of DUNA, Creative Alternatives for Peace, an NGO based in Bogota. She is a PhD candidate at Amsterdam University. She's a philosopher from the Andes University. She's a lawyer from Rosario University and master's in law from New York University. As actually mentioned in the practices of body, heart, and mind, and to see it in a context of transition towards peace. Dr. Natalia, welcome, and thank you very much for accepting the invitation, Doctor. Thank you very much. Janet, for the invitation. It's really a privilege to be here with you. I am going to share my screen for the presentation. I hope you can see them.
Sí, nos falta solamente la presentación en full screen y
If
el
you could do the
PowerPoint.
presentation in full screen, and it would be perfect to start. Okay, ready. Takes a bit my computer, but here we are. Well, we keeping in mind really the problems that we were dealing in Dr. Paola of mental health. The Duna Corporation, jointly with the program Connecting Families for Their Rights, which is a program that is financed by US aid and executed between the American Bar Association, Freedom House, PACT, and Internews. Among all, we thought that it was really very useful to think of innovative manners to be able to have to bring mental health to vulnerable populations, which is the migrant population. As you know very much, they have a very limited access to basic health and clearly to the mental health ones. They don't have any access really. So the idea of this entire program of to create a roadmap that would allow for some primary care. And God willing, with our hypothesis is that somehow they would work as a funnel so that they can reduce the actual number of people that needed specialized healthcare in mental health, so that we could have the number of people who are at their services is actually manageable from a standpoint of public policy and in terms of how costly these programs end up being, as was commented by Dr. Janet at the beginning of the presentation. So to be able to test if this route worked, we had a program in 4 municipalities of great migration, which are Bogota, Cúcuta, Medellin, and Riohacha, as the pilot or phase 1. And then we had into replicating this route, we were in Bucaramanga, Cali, and Barranquilla, living and seeing the impact that this road could have in the migrants. So we had also a goal, a very innovative goal, as the seminar says, that had to do with the stabilization of the central nervous system, aside from bringing to all the migrants all the interpersonal relationships and the community interaction. So we were kind of tackling the two main problems that actually generate problematic ones of mental health. One of them is the simulation of the central nervous system and the particular ones, and we did a typification of the population. And that is where a hypothesis came out initially, and that was that more or less 10% of the population needs specialized health care, and the rest, 90% of the people, may take care of their own well-being in terms of mental health, as long as they receive certain tools to be able to self-manage the condition. It's important that we had the development of these programs, a differential focus for adults and for children, and then another focus of the Guayu community, whose head office is in Riohacha. Now we had some direct people that we impacted there. Now, to tell you a bit in what was the innovation or the innovation in strategy, well, we got to local social organizations precisely to train them with all these tools that Dr. Paula was telling, so that we can have a certain installed base in the territory to be able to have a diagnosis initially of the people who come with some problem. And through these organizations, we had an invitation to participate of people between 7 and 90 years that actually came there with a vocation to stay in the system, and even sports community, which is also a key community that should receive this type of help. Once we had the beneficiaries there, we started with the measures which are pre-tail measures, and the one of health. You would be able to have this is actually quite innovative. It's not that we only apply certain tools of self-reporting, like RU and RU for Q for children, and then you have this continuum in Spanish. But we also apply something that we had never applied before for the program socially in Latin America, which are the biometrical measurements. We have seen that generally they have amplified the use of this report in the medical community because the people wish to continue to receive care because in certain cases they want to show that these things have worked. And what we wanted to do was to find out that aside from achieving these benefits that we were reporting in these programs, if we were also managing to have this fundamental aspect or dimension. And we take here two epidemiological tools and the microfacial ones that actually has to do with the response that people has in respect of everyday difficulties that they have to face. When we came to Colombia, we tested it there, and a very new one, which is neuroconstruction, is to see how do we integrate all these tools, psychosocial tools, in the handling of the central nervous system. After doing all these measures, we created intervention. Then we came the intervention per se, and I actually had two modules: a model of peaceful coexistence and rights based on the restorative practices about the joint work with the community that hosts us and to see differential how it would work, and then a mapping of the organization so we could create an environment of selection. And then in different territories we had a lot of offer, and other territories we didn't have there, and to map the organizations to which we can have access whenever we encounter certain problems. We also, the beneficiaries, receive a well-being module, and then they have good body and mental practices, then to have control of physiological changes and actually wish to regulate the central nervous system, and then to give them some capsules so that we can have there. What do I do when I feel depressed? What do I have to do if I can't sleep? And with that, we were hoping that they, as the module says, to self-manage your mental health. But after uh, explaining the modules, we applied the measures, we identified the cases that we had to send to specialized treatment. And then we went to a phase of follow-up and reporting that included or telling the social organization, look, this is what we found and how we do it. And at the same time, to rally those beneficiaries who to actually mention to them that they require specialized system, and the health institutions, if they could send or provide that psychological matter in the fields. And then we had, as I said, there's a variety of what we are having there. There may be a lot of offering one institutions, and then the other institutions almost nothing. The most impacting of the results of this route that we measured has to do with testing our hypothesis. And effectively, what we did manage to do is that less than 10% of all participants and that we had require specialized care in mental health. So only 8% of the adults and only 9% of children really require medication and psychiatric follow-up and all these costly investments by the state. Well, actually, to reduce the universe to 8 or 9%, we found it to be very useful because actually showing that it is a very low money terms static. So to put them into their systems and so on. So the ones that don't have them there in terms of psychiatrists and psychologists, if you don't have them, well, we saw that we can actually have them if you have these numbers. And we saw the many risks in the doctor visits, and in Bogota, we saw a large prevalence of the frame of depression, and among the migrant ones, there is a need that they have that we had not detected before for them to have access to the medical services in the biometrical results. These are some that have actually come about. All our measures outdo now. We do them always with independent universities of the highest quality. In this case, we were accompanied by Ohio State University and the National University of Colombia, and basically the doctors that went to the territories to different measures of cardiac variability. And this software was very innovative of the partial response that we still haven't received there to analyze all that data, but I wanted to share with you some of these preliminary data because honestly, it is, it created a great impact in me. And then we have a very short stay, or to have a very low cost intervention, have a really great yield for the money that you invest in there. For example, in this slide, measuring heart rate and cardiac variability, what they indicate. How flexible is the person to answer to stress? And what we found out later is that the information group increases the flexibility of people to be up to par, while the stress in the control group, either they remain the same or they tell you, literally, they tell you, okay, that flexibility as you time passes, you begin to integrate Colombian society, because after that, the ones who are executives in the data that they have the most innovative data in Latin America, what they're showing us is that we do have physiological changes even when you do offer to migrants and other vulnerable peoples this type of interventions early. We also have some results in the measures of self-reporting in the RUBQ. You could see the graph here, the difference between the intervention group and the group in depression going upwards is very notorious. And then what we have to see this, the statistical ones, for those who are not technicians in the mental little bar, is actually being to say that this difference here, this is effectively attributed to the illness. And you can have notoriously lowering your the way, if you want to use this path, or you could use this path and so on. There are many people that work very much in the cover, and then there are other ones who are not in the route, and they continue to do the normal attention that migrants receive when they get to some place where they do have care. This room of neurosection, it's a new one, and it's actually used that in theory of the theory of that you're going to have. But basically what it does is it shows you really how does it integrate people, the series of well-being. Emotionally, do they store that in the armpit, or if this very good in both areas? I mean, if you have that, psychological well-being, physical well-being, and how do you compare the changes that we had in a certain group before and after the intervention? And then you have the control there to have no change, and instead in the intervention group you have a very clear increase in the levels of the response integrated to the central nervous system. The same thing we have in the social level, and in being compassionate, so that you could integrate this to the central nervous system that not reach through time, because actually to tell you specifically how do they do them and facilitate them, and if you do that, it's going to be new, and to be able to validate this worldwide. And then we can do this exercise to assess migrant Venezuelan who came into Colombia, and then we see a statistical increase of significance in both levels of integration of these ones who are so important. And this is important as the social component to those migrants that actually made it there, to those who left last time and have not done so there. So basically, this is what I wanted to share with you, to say how something as simple as this can be very innovative and very useful for public policy. And in the future, so that you bring us a secretary so that we can begin to integrate the social technologies to the public policies that are offered to migrants in Colombia and that they offer it to population in general. So thank you very much. Thank you, Dr. Natalia. Excellent. The tools, excellent. The metering or measuring that you're doing, because this occurring there to enter and measure the central nervous system, as you mentioned, is actually very interesting. And there are several questions in the chats, both in the questions and answer, as well as in the other, how to know the tools that generated all these changes. I think that there are several people who are interested in coming to the methodology. So now if you could answer, and then in the panel, we're going to have more time to speak a bit more about the methodology that is being employed. So I'm going to give it now the welcome to Maria Fernanda Rodriguez. She's a manager of mental health of the measuring of the NGOs of Médecins Sans Frontières. She's a psychologist from the Santo Tomas University, and she's a magister of the Autonomous Mexican University. She has experience in caring and managing mental health in scenarios of primary health care, in conflicts of armed conflict, urban violence in Colombia, Venezuela, Mexico, and Panama. Her intervention, her lecture is Experiences with the Decentralized Model of Care, Building Pathways to Have Access for Mental Health Developed in the provinces of the Colombian Pacific provinces. Maria Fernanda, thank you very much and welcome. Hello.
Hola a todos y todas. No sé si me escuchan
Hi,
bien.
Janet. Do you hear me well? Yes, we can hear you clearly. Yes, we do. Oh, good. Nice to hear that. Being that the case, I'm about to share my screen.
Y me indican cuando ya estén viendo, por favor.
Ya la estamos viendo.
Yes, we're seeing it already. Yes, so you could put it in full presentation mode, like slideshow mode. Yeah, there we go. Yeah. All right. So experiences. So thank you very much for this invitation. For us, it's very valuable to be able to share part of the experiences that we have had with the BMC. And I tried to summarize in the best way possible the experience that we have had, because there are many of them and we've learned plenty with this model. And well, the idea is actually to be able to share a bit. And I wanted to bring Nina Maria Quinteno and Laura Jimena Garzón in this presentation, because they are the mental health managers of each project and they're key people in the entire running of the strategy. So I wanted to bring them here with the entire team that have implemented this in the territory. Well, actually, to tell you a bit, I wanted to tell you who we are. For those who don't know us, we are an organization, Médecins Sans Frontières. We are in 70 countries or more. And basically, we take care of people who are being victims or in the midst of armed conflict, epidemics, natural catastrophes, forgotten illnesses, orphan illnesses, and so on. And these are our focus of attention. We're actually are governed by humanitarian concept, independence, impartiality. We service all people without any discrimination. We don't take sides in the middle of a conflict. We never help someone from any and it's very important for us to know that we are decentralized and we finance ourselves thanks to people like you and people like me that donate. And that allows us to decide where do we want to be, how do we want to reach, and to be able to have a very principle to get to where no one has been there before. And that's why where we are. In Colombia, We have 4 projects. The first of them is an emergency team, and that's why I put the map of all Colombia, because it monitors the entire territory, and we do mental health assessments, even these care for emergencies. And then there are certain activities that they do in Panama with migrant people who are actually going through the Darien up Central America so that they can go illegally into the US. And then to tell you those that we service, another thing that we do from Colombia Mission. And specifically of the projects that I'm going to talk about is the project that we have here in the province of Nariño. And we prioritize 3 municipalities that are part of the TLMB. Then especially we have done our activities in Roberto Payana, and the office that we have is in Barbacoa. So the Barbacoa's office, the team actually goes to different rivers of Roberto Payana and the communities that are there to be able to implement the DMC. And then we have in the province of Chaco, which is the second project. The first one we have, Chaco, we have it since of last year. The other one was from 2021. And there the activities that we're doing in the High Baudo, which is this pink little municipality, and our office is in Miss Mina. Once again, our team goes to the rivers in the High Baudo in certain communities that we prioritize, and there we carry out the respective activities. Here, I just wanted to bring you a quote of a member of the Apatia Old Borough. Is a person that participates in the DMC as a community agent. No, excuse me. That actually he does the assessments that we were doing. And what we do is actually enter and ask the communities and certain players that are key. How do you see mental health? How is your community?
Del DMC y si hay algunas necesidades en salud
We
mental.
wait and analyze the data to give priorities of the DMC, and then we see if we can work with that, justify so that we train some community agents. So this is like a very quick summary of what communities usually tell us, what they tell us when we ask them, when we go to them, how do you feel emotionally? Which is kind of what we identified here. And I actually felt very aligned with what Natalia says, with anxiety level, a very high one. There's post-traumatic stress disorder, depression, and other types of typologies. And people begin to tell us in different way, and then they tell us how the community is at the mental health level. All right. This is sort of like for introduction. I think that's good. The topic. Now, what is this about the DMC? Well, DMC is the decentralized model of care, DMC. And basically the strategy has been thought through to be able to bring communities closer to the primary healthcare services. And this starting for the communities, because for communities to have to travel to where the medical services are available. And that's why I put it here in color to mention about the barriers that they have. So DMC actually pays for everything, and there were Africans and so on. So for us as authorities, we want to know, how do we handle this? How do we do it here with these realities in our territory? So on the one hand, we found geological barriers that are significant. Communities are far away, that, as I told you, they can use other different means of transport. It's actually for the rivers is actually based in situations that are very complex, and perhaps in Colombia with the signature of the idea that conflicts has finished, that has been diminished very much. And the reality is that no, the conflict hasn't changed very much. It's still alive and well in the remote areas. And then we have economic barriers. For communities, is actually more costly to move from one community to the next, to a capital city, than leaving the country. I mean, it's actually cost millions to be able to move there. So the gaps are enormous in mental health aside from that. And I think here that I was putting here, there are very few specialized professionals in mental health and psychosocial support. I mean, to find a psychology, even in the largest town in the municipality, finding a psychiatrist, even worse or more difficult. And the professionals are not really trained or know how to work, how to care, how to accompany the persons that have uh, mental health issues, even though there may be light, moderate, or severe. So that's why what I was telling about the image gap is that it's so important that they get there to the places where they're more isolated. There's very intercultural focus, and it's actually to mention in these areas where you have different ethnias, cultures,
encuentren atenciones que comprendan las
it
cosmovisiones, las
would be very difficult to find caregivers that understand the culture and the customs so they can give them professional aid. There's lack of knowledge of mental health because although we have found that for communities, when we ask them what is mental health, there's like, oh, what is it? I mean, is this, we don't know what's a mental health. And when we begin to ask more in detail, she does have the one that is so clear what are the impacts that are very telling, because although they name them in different ways, they understand that it is mental health. But then we find other people that do not know it, that don't understand very well the identification of their own emotions, the emotions of others, practice that perhaps you've heard before, like discriminating people who have some mental health illness and they're perhaps they don't think it's very dignified and don't know how to handle the situation. Situations and of the professionals, the doctors, nurses who are at the health post and are the promoters of health. They don't have it all that clear that what is mental health and how they can accompany it. And then we find very important needs in mental health. As I was telling you, what we find the most is post-traumatic stress disorder, and they have levels of stress that are very high. Would they relive the experiences of violence over and over? They have them like images in their head. That is what we call flashbacks. They hear a loud bang and they're scared. They're going to ask, at what point in time is the fight or shootings going to begin? They actually said that we don't know at what time we're going to start with the pa 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 pill, which means the shooting, and they begin with fears, anguish, preparing all the time with their bags ready to just start running. And this is a bit near anxiety. And then we find difficulties that are very strong in respect of the issue of suicide. Suicides that actually did occur, and statistics that are quite alarming for communities that are so small, and that they actually affect the entire dynamics and the structure of the community. When this happened, well, I hope you've actually, if I have enough time for this thing that we have found, there's the dynamics of sexual violence, gender-based violence, and little access to the path for care. They can't leave the community. They don't have the access. They don't know how to get to where they need to get. And this is a bit in what we have found in mental health. And we have also found that in certain territories, not in all of them, there are ones where you have a psychologist and some skills they have to visit the territories, especially in Nariño. We saw it there that that person in somehow they can go and review how the persons are and to offer some accompaniment or so on. Certain communities, but in others, since from the capital ones or some ones there, they offer them virtual care, which is a topic that is almost impossible in where they don't have signals, and then we have mobile there far less we're going to have internet, and therefore that is not really, it's not feasible to provide something like that. I mean, well intended but not quite there. And here I have certain components that are very important to understand what is the DMC and these barriers that we have had and how we landed all of this. So on the one hand, we have a component that is anthropological and that allows us to understand the entire culture. in which one we're going to come close to to understand the people, what are their conceptions in terms of health and the conception in terms of mental health, the health practices, how are the searches of health, everything that actually is around health and how we signify it culturally. And actually we do some activities that are promoting activities in health. And now we have a component that's super important is the involvement there. That's why I put it in red, because it's a component that we found it to be key, and it has a psychosocial principle that is very powerful to involve them. It has to do with how do we begin to weave the social fabric, and how do we build trust dynamics, support dynamics, and then to be able to understand, as I was telling you, what is your vision about the world, what is your culture, and what are your health practices, and to weave them there with the proposal that we bring, so that when we can build the dynamics and a proposal that really worked. Basically, so what do we do here? To bring it more down to earth, we do training in the territories with people with whom, from the DMC, we call agents and community promoters of health. These people are actually trained in basic concept of in regular health and basic concepts in mental health, so they can provide first or eye services, I'm sorry, ER services we can do, and we can have one instance within the community if the person doesn't need any reference. And then here, to bring it more down to earth of how we do it, we actually bring this like this route that looks very well paved and very nice, but really at the DMC, we find that the path is not that beautiful or paved, but is rather complex ones with a bunch of challenges, a bunch of batches, and then to us to go back, and it's kind of a spurt because we have to kind of be constantly refeeding back on what we're doing or trying to do, and that what do we need to correct. And then we have the elements that are central, which is the cultural one, that's a key one, so that the DMC works. Choco has some intercultural barriers there. So there we have there in the majority that we work in Choco, we work with the indigenous community, although there are many Afro communities there. And in Naricho, we work with Afro communities, but we all would need that the communities and certain figures, specifically in Choco, we have two mediators that are intercultural that are with us all the time, or of the DMC staff, and they help us to validate all the tools that we apply there, to test them, to see their formations, and so they actually pass through their eyes actually kind of filter this, and yes, this looks good, this doesn't look well, this is not clear, this is not understood, and so on. And that way we assure that what we are proposing, that what we bring to the community is actually going to be applied by them. And then the simulation component, which is more of a methodology that is specifically in Choco, that is actually very much of role play, very well to put them to practice, that the people actually are trained not with theory, because we know that it doesn't work that way, but rather we have to put it into practice. They have to live it, they have to feel it, they have to experiment it, so that there they can there learn and take them to their communities. Yeah. There are several elements here with which I'm going to pass quickly to this. So I'm going to tell you this, the importance of getting involved, the trust level, that we do some evaluations, we come close to the communities, and this is also across the board, and we're always building trust, and to work with uh, community involvement, community participation is very social and psychological. And when we started, we select the community agents in health, and we see there that they have a very much selection components, and there were some characteristics that we were looking for in the agents. So for example, in Nariño in particular, that we were trying to make sure that they were literate, that they did have certain age, and then we realized that really what we need is actually perhaps it's a different types of role, people who actually have like a positioning of health in the community relevant of whether they know how to read and write. And that's when we begin to think and rethink. So that's why I saw that the road is very circular, as you see there, because there's a lot of feedback for adjustment. We have actually have tried to build a relationship with them, because of course the DMC is not going to run very well unless they're very well formed, very informed, or they have all the knowledge, and that's what we want to do on the remission, and then the structure doesn't receive it, or they give them the run around, or they don't understand the mental health. So that's as far as the process went. So we actually have, with all these health structures, we try to accompany them and to see what they need and what we can provide support so that they can facilitate that access to health. We prioritize certain topics, especially for mental health, and we do it for the signals and alert symptoms. How do we identify certain mental health one? How do we do uh, psychological first aid, some screening? How do we do screening? How do we do referrals? And then we prioritize ones for each one of the municipalities that we work in, and we do the formation with the agents that they're all going to be crossed by efforts. We're going to see the topic, where do they need some backing, and we do some supervisions out in the terrain. So the managers and the psychologist teams, they go to the terrain, they review the cases with them, they actually classify something as an urgency or an ER or an emergency. What was this? Then why did we do that? We do the entire accompaniment fully, and a bit of the work of the agents. We translate references in what they do with health, the ones that they comment to us, and we end up accompanying the process so that the person finally receive this. And lastly, we have a component of incidents that has to do a bit of what we do in the health structures with how to do we put these alerts in the need of having professionals that are trained in mental health so that we can have a psychologist and, well, this, as I've pointed out, which is signaling and accompanying there so that we have the necessary mental health accompany. Here, I wanted to share this article that we wrote based on certain experiences that we have had in Choco. As I told you, the issue of suicides is a problem that is quite dense. So welcome to read it, and leave it there so you can do it. And then as we finish, and then that we have there of the experience of the DMC, and then we have of the ones in there, the communities, and that we have there that we cannot be vertical, and then to come there, medical ones, and then we have there to know of what people there is, some knowledge, and to do some medical handling there. Then we have the Haibanas and what they do in the basic community, in the indigenous communities. I take that back, in how we work with Chilco, and we work with an Eradovida tribe. And then we have some traditional medical ones for each area. So we weave like all these know-hows, what they do with their communities, and how we can contribute for the health and the mental health, actually be more cared for. We also understand that the issue, that the violence, the gender-based violence, is a complex issue, and that we should prioritize and provide care. There are many cases that have been of very complex handling because of the pathways and the difficulties that we have, and they're quite strong, even with risk of suicide and DBG. And then we have the community, they have their own understanding of mental health, and that's an important one there. We have there, then we have the teamwork, then we have there not only mental health, not only with the community involvement, but also the component of physical health of them. It's actually, we've had, it costs very much to bring them to the territory and to do them with all the guidelines that the militaries have. And then we have that are so complex. And then where we have there more of the strategy that works. And it's actually very super important to understand that this is a resourceful process. It's a spiral. We have to keep on touching upon it. It's not that easy to understand. It's been very challenging for the projects and for certain positions within the projects, and to understand how it is needed to accompany the mental health processes. And here I would leave you a quote by Lena that when we were speaking precisely of how has experience been at the DMC, and she was telling me that sometimes we think that the people are just they don't know anything about it, and we're going to teach everything that we know, and people do know. They have their concepts, they understand, and they give it a lot of importance. They open the door so that we work in the mental health. So for us, that has been key to understand. And now I just wanted to say goodbye with a picture of this activity that we had yesterday that for us was really beautiful. It was like a venue of closing. These are the community agents that yesterday they graduated as community agents in mental health by the directors of the local ones. And they're the director of mental health, and then we have the DMC team. And below, we have the two members there of the component of mental health and the psychologist, and then we have
Entonces, nada, eso era lo que quería
a flip
compartir.
chart that we had that it finally got there, and when we finally got it, we used it. Thank you very much. Thank you very much, Maria Fernanda. You have the video. Do you want us to take a look at it? Do we have time for that? We have 4 minutes.
Estás ahí, miramos si tenemos el tiempo para mirar el video.
Nos da tiempo, es un minutico. Lo que
Sí,
quiero
adelante,
compartir.
adelante, por favor.
Entonces,
Bueno,
si usted lo quiere proyectar o lo proyectamos nosotros.
déjame ver si lo logro.
Ok.
¿Se ve?
Let me see if I can do it from here. Can you see it? Let me see.
Lo estamos viendo.
Perfecto. Me dicen si suena.
Yes, tell me here if the sound works.
No está sonando.
No, not the sound. No.
Es mejor que nosotros lo compartamos.
No, let's see if we can share it here. Okay.
En el
Juliet.
segundito
Okay, perfect. Yes.
48, gracias.
Juliet, si tú lo puedes compartir en el segundo 48. Listo.
If
Eso,
you can
gracias.
share it in second 48, it would be there. Yes, from 48 seconds to minutes. And these are community agents of the one that graduated yesterday. So I thought it was beautiful to hear from his own voice the experience that they had with the DMC in mental health.
Juliet.
If you want, you could like forward it quite a bit, Juliet.
Eso ahí, gracias.
Yes, there, right. Hi, the ones who work for health. I am Carlos Sevillas. I am a community agent in health, and I'm going to tell you a bit of what I have learned in mental health. I have learned as to what is mental health, what is a mental problem, what is a mental problem. I've learned about the psychological systems, what are the alarms in children, in adults, so they can have a crisis of as to what situation they may have there, about what are the relationships among children, teenagers, and adults. I have left out the factors that can generate. I've learned as to what causes can generate some mental health problem, as to what population is most vulnerable in this situation, on what can we work so that a person can feel better, as to when can we find one that actually have the ethical principle in care of a patient in mental care, as to what are the pack, who can actually provide pack or who can give psychological. I have learned how to identify like the behavior of a person. I have learned about the criteria that we have of reference for the care of a patient in mental health. How I'm going to apply it in my community? Well, first of all, in psycho illustration, in chats, I have to make the community understand as to what is the true meaning of mental health, as to what is the difference between mental problem and mental question there. See if you like, Juliet, we can actually pause it there.
Gracias. Quería compartirles nada más este pedacito que nos
Just
pareció.
wanted to share that little there. We found it to be very valuable, and to hear one of our agents, we feel very flattered of the work that they have done and all that they have learned and what their communities have done. Is actually a challenge for their own mental health. Excellent, Maria Fernando. Thank you. Thank you very much for sharing the experience, this video, and congratulations about the work, the training work that you had yesterday. I am going to pass it over to Dr. Arturo Harker, a PhD in economics in California, Los Angeles, director of the Center of Mahina, and associate professor of government in the Andes University. The central topic of his research agenda is the development of human capital. He has worked of understanding the impact of adverse child interactions as violence and informal education. He has actually measured the ones and mitigate this impact. He's the last of our guests in this afternoon. He's going to speak about the implementation of psychosocial support in context of extreme adversity, lessons of the seeds of APE. Welcome, Dr. Harper. And I'd like to give the mic there so that you can do your presentation. Thank you very much, Annette. Do you hear me well? Yes, we hear you perfectly. Well, thank you very much for this invitation. Really, truly, it's fascinating to be here and to share this space with all these experiences, what Maria Fernanda has had. For me, it's actually marvelous what they do, Natalia, Paola, and I took notes, things that I wish to ask after, but I am going to start to project the slideshow, my slideshow. I am going to tell you about seeds of attachment, or semillas de apego, seeds of attachment. And there it should be in, yes, full screen, I think. So seeds of attachment, or semillas de apego, starts from a motivation that we have actually mentioned in Colombia, adversities and trauma that has been generated to violence, spending. And if we measured with the Venezuela migration crisis that has had decades of migration in Colombia, it gives us more than 11 million people who have been forced to migrate. Among them, more than 1 million have been children between 0 and 5 years exposed to the armed conflict, and more than 300,000 children that we have registered from 0 to 5 years that actually come from Venezuela. What else do we know? And this is broadly documented. And then we have there the health of all members, but in particular, in those first years of life, it does have a very important impact in these potentially traumatic experiences that affect the development of the brain, the health, and all these processes of development that have all the skills to manage to develop all of our potential. So these seeds of attachment start to kind of break that vicious cycle and to re-give new opportunities to thousands of children in Colombia, to allow them to have there in Colombia and then elsewhere, and then to finish that cycle that perpetuates the transmission of poverty and lack of opportunity. At the end of the day, what we want to do is to promote mental health in families affected by conflict, forced migration, and other environments or adverse environments. And we know it's essential that all children have the maximum of their potential and well-being that they need. Attachment seeds, it's a broad work, and more we're going to tell you about. There is a program of psychosocial group intervention that actually seeks to promote mental health and development in a context of violence and forced migration. And here, what is important is different from other programs that actually work with caregivers. And I think that this is interesting that it brings a different and innovative that sees bring. And then we have, it comes from prioritizing is never a good idea. It actually comes from the first sector, and that is an integrated factor that it actually has attention and services. And then we have between 0 and 5 years. So what we do is actually work so that mothers, parents, all caregivers, I'm going to speak with mothers because are the ones who most frequently work with us, and they manage to have the tools that allow them to process their life experiences. They have a better comprehension of the infantile development process and how these adversities affect this process. And in this way, we find that they, the main caregivers, becomes actually in a actually support physically. So this comes, I'm going to tell you a bit of where does it come from originally, the program, but it actually comes from all the theory and the evidence that shows that these affectionate ties are the ones that actually work as a mechanism to create a protective shield that promotes the early infancy, even in these environments of extreme adversity that we call. What is the evidence? For us, we actually national or international evidence that shows us how all these potentially traumatic experiences affect the mental health of a child, and it also affects the mental health of caregivers. And perhaps the most important here, it's to be a double risk, is that actually the mental health of caregiver is the one that actually provides those emotional resources so that you generate a safe emotional tie that actually has a double impact in violence and displacement, about the same development of the children through physiological environments. And then we have there quickly, then they tell us they all have stress, and that's a mechanism of survival that has helped us to be successful and to prevail as a species. But when you have too much of it, makes the system that actually handles the stress in the body, the hypothalamus saturates, and that affects not only the behavior of people, but rather when those people are in those development stage like early childhood, in that window of opportunity, they affect the brain development, as how the brain is cabled, its architecture, and that affects their entire life trajectory, the probability of risk in health, transmissible diseases, non-transmissible diseases, the probability of success as student, as worker, as a member of society. It also affects its trajectory in all of the dimension. And there is evidence from the harshest of measurements like this one of brain connections, comparing children that have an environment of adversity and the ones who don't have toxic stress. And this all happens at that time, in that window of the brain development, where it is having certain processes where millions of neuronal connections. And then when doing so, you need to have that emotional tie and assurance. So the brain architecture is affected because the amount of neuronal connections are very few and far between, as opposed to in a normal ones you have many. There's like all of the ones that we have here in the prefrontal cortex, and that's where we help to regulate the emotional and cognitive processes. So what do we do in having ties there? To take care there, to promote the healthy ties in the family and to strengthen the upbringing groups. This is kind of the way in which the program flows. So what is innovative about support, this support seeds, or this one's about the capacity of the community psychosocial ones there, of the seeds of attachments. They actually are local mothers. We also have a profound adaptation process of everything that happens in the curriculum. And these are some principles that are very clear and are not modifiable, but everything around those principles that adapt so that you have appropriate and relevant. And that is very important. I think that uh, from the onset, we have learned it here because it's worthwhile, not because we think of it, because we have done some assessment. I'm going to tell you a bit more of the impact assessment that we have, but actually assessment of processes where we have spoken with the community, with the participants, with the monitors, with the different players that are in the program, and they actually have given us the evidence that we have had of that adaptation. The fact that we have the communities being very important. So, as we have said, the model is actually very implemented by community um, players, their mothers or community mothers, and they do have a training that is evidence-based and hands-on training that is viable in any community because they are the mothers or caregivers that actually go through the program, and then they're part there. And then we have there in the groups, and there's something that is key that we have mentioned, and it's fundamental in these interventions, like in any other psychosocial intervention, and that is that we have a supervision, reflective supervision, that we should not, a supervisory network, you should not call it that way because initially they called it a supervisory there, but actually we have there that the focus there is to protect the emotional well-being and coherence in the relationship of the facilitators, of the psychosocial monitors in the program. So this supervision does have a lot to have and accompany them so that they can actually accompany them in their own process to facilitate the typical labor risks that there are in being a community agent in mental health, in psychosocial ones. And that's kind of the burnout of the trauma that one could have in that type of risk. So in general, in these three modules that we have, we first have to work of the mental health of the caretakers, then we develop those healthy emotional ties so that at the end we can have not the burnout of them, so that we have 15 sessions. It's actually once a week, sessions between 2 hours, 2.5 hours, sometimes three. And these are group trainings where we have 15 participants, and it varies between 12 and 18. We have had, it varies, but on average, it's about 50. They're led by two community monitors, so they're trained and actually they actually are accompanied through some supervision that we have mentioned. The first module seeks to promote the emotional regulation of your own feelings and emotional behavior, and actually want to leverage the resilience capabilities and the personal ones of the care takers, so that you can have that vision, or let's just say to optimize as to what are our assets in this space. The module that promotes affectionate ties is actually strengthen the curiosity, internal curiosity process of children and how they are affected with adversity, and it wishes to strengthen these ones, how to generate protection and assurance to the children, and to identify manners of how to do care relationships with them, so also to strengthen the repertoire of upbringing strategies. And here there's something very important, is that when we work with this program from the early childhood, we have to ask ourselves, well, what makes us that this is more a program that is actually, rules about upbringing and so on. And here, I think that in this part of the program of this module is where we have the answer. What we're seeking first in that first and second module is to create, actually to help the caregivers recover their emotional resources. There's an anecdote that we have actually had of Vilma Reyes, which was a researcher that helped us to develop the program and adapt it for Colombia. Actually, not to generate the Colombia version, not adapt it. And this one was telling us that a mother comes to a place where they used to take care of illegal migrants, in California, where Vilma works, and that she was telling there about that one had been a victim of intrafamily violence and crying, and she had a child in her arms and a 3-year-old child. At that time, the child fell. He was running and he actually fell, and he's actually going through a difficult moment, and he actually comes running to the mother, and the mother, at that state that she had, her reaction was actually to stop him and tell us, "Don't hit me." And this is one of the anecdotes that show of what these levels of attachment. It's not good or bad parents or good or bad carers. It's actually turns out that in certain situations, in context of adversity, the emotional resources are just not there, and they're not there to be provided in this wonderful window of early childhood. So we need to do so. That's why we have to start from recognizing about the context of the caregiver and how they affect that affectionate bonding. In this last model is what we want is to consolidate an upbringing group so that we can have like a graduation and we can have like some empowerment, some trust to mobilize members of the community to continue that path that is going to continue to be difficult, and to create a support network among the group, right? So that's basically what I mentioned. These are the 3 dimensions where we work and so on. So the story of these ties, we started in 2014 designing the curriculum. I'm going to tell you more about that. And now we're about to finish this first step of upscaling, and we're actually going as upscale of 2026. And I'm going to tell you quickly about that stage. And in 2014, we began to work with a team of the research group about infantile trauma led by Alice Lieberman, one of the ones of the theory of attachment. She actually had the theory of attachment with trauma, and she started a program with Patricia Van Hoen, her colleague, that is called the Sandpart Psychotherapy, the Psychotherapy of Parents. And it's a program that has some 5 impact evaluation that is actually in many states of the United States and in many places of the world. And it actually lasts, if I think it's like 32 weeks. It's some direct work with the mother or the child of that the couple or that group or a psychology student. And it's very clinically very difficult to upscale. It's actually very difficult to take to the territories, and that's why they begin to work in a group version, which is actually building bridges. And at that moment is when we started to work together, and we managed to actually have through a lengthy process of appropriation and adaptation and research here, we managed to have a Colombian version of the models that we have, which is called these seeds of attachment. We had support from the health ministry, and we had something that was very interesting. We thought that this was the attachment level was going to be the vehicle to go upscale, to make it feasible, and to have that one for victims. And we work with the Secretary of Integration, and we did this with 75 women that were displaced between 3 and 5 years. And there we captured information of the ideas to see that this was relevant, viable. And there was some great satisfaction about the members who participated in the program. We gathered the information. We seen how we were working in the other presentations to see how what we will be able to measure in the area of exploration. And then we went from Bogota to take them to a territory where we knew that the need was just total, and where the complexity of bringing that to the program was greater. At the pilots, we worked alone with professionals trained that had a lot of experience in delivering this type of program, and they became the trainers where we got there. And there were 6 mothers from Tumaco became the monitors of the program, and the ones that actually gave the program in Tumaco between 2018 and 2020. And then we got in that phase to 13 170 mothers, and then we did impact evaluation where we had the standards of the impact assessment so that we can have a proof of concept to see if there was effectiveness in all of these dimensions that are already cited. And these were actually a satellite picture of Tumaco, and this red program is at the centers of child training where we deployed the initiative, the schools basically, or kindergarten days. We didn't do it within the PVIs. That was another of the things that we actually had. We had to do the attention due to the lack of infrastructure. We did it outside there, but the experience was beautiful, marvelous. And we found that 8 months after we had finished the program, we didn't wait because they were 8 months later because there's no means there to finish the project. We found that there were a positive impact in the healthcare of the care provider and the quality of the affectionate bond, in the type of frequency and the interactions in the mental child health, and then in the early child development. All of these graphs actually show there. It actually shows where the size of the impact, if they don't cross that line, in other words, that they're statistically significant if they come there. So in mental health, we can see drops of 46% in actually having the anguish feeling, and then the other ones of depression, and then 59% in what they have in their sensitivities. Now, in terms of the three parents, which is a measure, there's is a scale of three between the relationship between the mother and this is the parental stress, I beg your pardon, and it measures the stress between the mother and the child. And in child mental health, we see here in 36% we have the probability of developing symptoms of anxiety. 43% of them are having symptoms of depression, and 36% of post-traumatic stress. So all of these scales have actually had the advantage of piloted them in Bogota to see how they were, or actually having taken from other studies in great scale so that we would know and make sure that it did work or not. Finally, we have interesting impacts in the social, emotional development of the children, which was the end goal to begin with. We see that the program here of 68% of the probability they have of the social emotional skills, and then the probability of having critical levels in behavioral problems, and we're speaking of critical ones, they all have a risk threshold. So our interpretation, we take it as if the children leave those risk level. And here we are comparing a pre-post between treatment and control. Right now, we are in this part where we're ending there. We are about to finish it. We started last year. Is our first upscale process where the focus has been to understand what do we need for these mental programs to actually work, and actually leads us to new municipalities, new communities. That process, we in Tumaco, we saw it in a very clear way. In how to start in that new territory is complicated, not only because of the adaptation. It's a process that we have to go in depth, but it's actually an issue of trust in the community. Now, to have some attachments, it's a reference frame in Tumaco. It's easy to open doors. Parents want to participate. It all flows. It was not like that in the first part that we ran this program today. We're doing others, and the idea here is actually to begin to work with an operator, which is Heartland Alliance International. They're the operator, and they're the ones that integrate the model, that they understand which were like the needs to bring with quality the programs, and what were the non-negotiable, and how could they help to improve the management. It's been a wonderful cooperation, and fortunately, all of this evidence as to how the program works, that it's effective, what makes it work and turn it into upscale, we've gotten to a new stage that is a formalization where we're bringing like 13 municipalities, and the idea is to get to 15 1,000 caretakers and 1,000 early children once we're actually evaluate, excuse me, not 1,000, 22,000 children in early childhood, and to get to more territories, but also to try to understand what can we measure. Measuring always of thinking in this continuous cycle of quality improvement. You have to measure, to adjust, to reiterate, and take out a new version. And we are here. This program is, it actually presents what early childhood represents. It's a broad collaboration of different people from all walks of life, and all this work from the California UCF. And then we have also an alliance with what used to be the genesis of United Way. It's United Way Colombia. It's a profound support there. And now with Heartland Alliance International as an operator, but the support has been broad and financing for the implementation, for the evaluation. And they have actually read it there. And then we can see that this is the Canadian cooperation. And today we are working in an innovation to incorporate materials in the workshop. And then we have an interesting project in the upscaling. And Edith has always supported us in these topics. And well, with that, I think is, and there are many more who can help us there. And this is what I wanted to share with you. And now in the discussion, I can mention other things that may have to do with this program. Thank you very much.
Muchísimas gracias, doctor Arturo.
Thank you very much, Dr. Arturo. Really, congratulations also for the program, Seeds of Attachment. I mean, it's a beautiful name. Seeds of Attachment is a beautiful name of the projects, the results you have just shared with us, the possibility of upscaling to other provinces in the country, other places. Truly, I mean, congratulations. We have seen certain beautiful experiences and very valuable experiences, as we said at the beginning. I am now going to give the mic to Luis Gabriel, who's going to moderate the panel. With our guest speakers, we have some questions that in the chat and in the Q&A option we have there. So, Luis Gabriel, please, the mic is all yours. Thank you very much, Janet, and obviously thank you very much, our guest speakers. Excellent presentations. Good afternoon to the audience that is here with us, and actually invite all members to have questions through the Q&A section and in the chat there. If you prefer to raise your hand, you can do so as a preamble to the questions that we're going to have to our guest speaker in this very few minutes that we have. We have to mention that every $2 of $3 of the very scarce investment in mental health care, they're actually designated to psychiatric hospitals that are independent instead of giving early first care. This is from the report of 2022 of the WHO, and they have committed to have a mental health that they have written in 2013 that is oriented to improve mental health through leadership and governance that is more effective and providing a full, thorough one and attractive to the framework of a community and the applying of strategies of prevention and the strengthening of information system, the scientific data and research. This action plan actually proposes 3 ways of transforming them in the country to improve substantially the mental health. And that is 1, to increase the commitment, investment, and value that they have for the people, and then the community they have for government. And we see how this bet that they've actually presented, they've done that advocacy so that all the components of a society identify the value of that and place their money where their mouth is, and then to have the physical and socioeconomic environments and work environments, the community in general, pursuant to protecting and promoting mental health, and not to have the psychosocial affectations. And then we see how these examples that you've given me, they come there where they work in the neighborhood, What we need to do is to encourage education and mental health. And third is to strengthen the access and quality in mental health through a community network that is interrelated. You don't have to wait for them in the hospital. You don't have to wait for the health center. You have to go to the community there where no one gets there. As Maria Fernanda would say, you go have to find them there to promote mental health. So this in a very broad concept of what is primary healthcare, not only written to providing health services, it is there where we have to promote mental health and handling it. So the first question that I want to pose it to Natalia Quiñones, how does one translate their emotional regulation and the development of social emotional skills in transforming community dynamics that promote peaceful coexistence and collectively improving mental health of the others? How could the system be implemented in these exercises there's every day? She's a pediatric doctor. She says, in the very few minutes that we have, how could we incorporate these innovations and questions to evaluate there? So I'm going to ask you, but given time, you can actually respond very brief and concisely to give space to other questions. Thank you. Please, your answer. Luis Gabriel, thank you very much. Is that what we have developed precisely is some capsules that are specially designed for very specific situations and that you can have in the presentation and here. What do you do when the person can't sleep? When the person complains that is feeling sad, if they're having fears or whatever. So these are very important sequences that you can transmit very much to the person that has to do this. We have a pedagogical materials with little comics and the like, so we can share with the community that needs it. And there is a training by the entire route or roadmap that we have actually done. And its goal is actually to train people in the community, especially in social organization that want to work in this. And it is a training also that is short and efficient to be able to have them nationally provided. Thank you very much. Dr. Harker, from an intersectorial perspective, how can the health sector learn and articulate what Natalia was asking? How can one learn to articulate your actions with support network of community-based ones by the armed conflict in Colombia like the ones that you develop? And I think that this can actually help us to answer another question that is there, and that is there was an expectation that we spoke more about the mental health intervention from the mental health, but we wanted intentionally to open more to what we do in primary care outside of the health system. But how do we transfer this knowledge to the healthcare providers in the healthcare post? Well, thank you, Luis Gabriel. When you work, for example, in cities where the network of services is actually very nourished, very strong, like Bogota, for example, one sees that there is some articulation between the formal educational system and health. There are some means to orient the person that need the ones, the mental ones, and there you have some systems, right? They should be improved further, yes. But the same thing happens with these type of programs of care, the psychosocial ones that actually display through the services or, yes, the services of early care, of early childhood care. But these are difficult to identify for the ones that require more attention. What happens with pediatricians and other type of to enroute people to other type of systems that a pediatrician cannot give. So in this case, we have the opportunity to achieve that all sectors, they can be routed, and we have to go into macro. As a matter of fact, it was possible at the beginning, and it was actually more viable because in Tumaco, the mental health services in one case was critical. And within the criteria of inclusion of the program, there was one of not being in a need that is over and beyond what can be provided in these attachment seats. And then we had Médecins Sans Frontières. Unfortunately, with them, we just routed the cases that actually can live, they lead certain people to have the care that we needed. I think it's fundamental that this parts, let's just say that all systems in obviously they're actually called that are trained in trauma. And part of this is actually is that there are certain situations where people need certain services and we need to have very clear what to do. So all these programs that you have spoken about as to how to have very clear as to how to care even more there over and beyond the crisis, the immediate crisis, like the first aids. Then we have to see what comes next, and not only to remit them to another institution there, but I think that the services that we have since early childhood are fundamental there. And I think that we have it more clearly and more explicitly and to demand it more from the system, or at least what I know about early childhood. Right. Thank you very much, Arturo. Definitively, there must be some communication between the different sectors and the service providers and the ones that actually do mental health of community base. Natalia was showing us, just like Maria Fernanda, how are those routes and so on when they identify what they're doing when there are situations of medical personnel. And as you explained, perhaps the challenge that we have is how do we articulate the the health system systematically, regularly with these type of players and actions so that they don't end up becoming in anecdotal situations and experience or isolated efforts. I know a friend, maybe I call him to see if we could care. That friend-based structures are not presented or they're not there. I don't know how you see it there. This medical task that you do in the identification of cases that require like more regulated ones specialized there in this the health system. How do you do that tie and how they have helped that more than what you actually presented of how you've generated capability at the community level? How do you strengthen these capabilities for the very care of the system for the time when the mission ends because Médecins Sans Frontières will leave? So how would you do that? Please, what's your answer? Well, Luis Gabriel, really, in truth, it is a challenge. It's very complex and it's one of the challenges that we have here on the table at this moment with the project with Chocó as well as with Nariño. With Nariño, it's been a bit easier because there's some capacity already built at the healthcares, and they have there in the hospitals. And then there's a psychologist, there's some doctors, sometimes there's only one doctor. The manager has actually establish a relationship with the manager of the hospital, and from there to facilitate that the agents actually build ties with the health institution, with the health structures. But that is a process and it's a great challenge. With Chocó, it's been even more complex because in Chocó, it actually, you have this situation of the one that I was telling you about, the discrimination very markedly towards indigenous communities. So when they're going to come close there, in spite of the fact that they have their own health ones, when they come to certain structures, they do not receive the ones, sometimes they deny the service. And these communities are far more distant, far further away from the health section. They don't speak Spanish. That is another super challenge that we have had. And for example, in Chocó, we've actually back in the hospital, that we have there, like an intercultural mediator. And that is a figure that I was telling you about, this person that helps us to validate all the instruments that translate, that helps us with the training, that actually helps us there in certain sections that we do in mental health. And there's a people there, which is staff MSET, and they're in the hospital to help how to do that bridge to facilitate the process. But I mean, really, it's a huge channel they access in territory, the territories that have been so hurt and there's so little presence of the state. And that is very costly there to have this relationship and to bring the agents closer, the structure, so we can have a tie that actually facilitates a tiny bit to have access to that. It's curious, really, that these are projects or external institutions to the system or to the local government and to the regional or national government, the ones that take the initiative of interconnecting. One would think that it would be actually initiative of
Esa labor
governments,
importante que
but sometimes it just doesn't come through. And that important test that you made, of
María mencionó,
advocacy
son
that
importantes.
Arturo has mentioned, that
Aquí
these are
quiero
very
preguntarle
important. And here I want
a la
to
doctora Paola,
ask
para con ustedes
Dr. Paola, and then
usted
soon I'll come
tiene
here. I know Arturo, you
la
wanted to say something
doctora
else, then
Paola y
excuse me.
quería preguntarle
Now, Dr.
precisamente qué
Paola
experiencia
wanted to ask something precisely. What experiences are there nationally and internationally in respect of the use of the MH gap and the global health,
Global Mental Health Assessment Tool
the governmental
por
health assessment tool
expertos en salud,
by
porque
technicians in
mencionaron
health? Because you mentioned it
el
really,
ámbito que
and it
podría
was described that
hacerlo, sin
they
embargo,
could perfectly do so.
brechas que
However, considering the gaps that you can find there in what you have acquired
cómo
before,
es la mejor forma
what is the best way
presentarlo por esta vía y
to
cómo dar
prioritize it
seguimiento para que
and how to provide some
no
accompaniment
vayamos a
so
tener
that
errores de
we
diagnóstico
don't end up committing mistakes in the diagnosis and the appropriate ones of the people that require the care, specialized cares, and adequate management in primary care. Okay, perfect. Well, look, the first things is that these tools, when they're designed initially for primary care in health, they have actually been thought precisely in the professionals that we need to find at this level. So initially, it is a tool designed for doctors, nurses, social workers, psychology, occupational therapy, for example. But in reality, we have seen that aside from this specific group, many a times there are broader groups of people that actually have there that receive this type of training, of people that actually have administrative and managerial posts that not precisely are dedicated to the clinical practice, up until persons that are not from the health sector, but in the place where they are located, they end up being health reference frames. So at the community level, teachers, faculty, even spiritual leaders, that they are the precursors of many of the problematic situations in mental health. So let's just say that their application has been broader for what we were designing these instruments. Now, the benefits of these strategies is that since its conception, they are adaptable as per the audience that I am addressing. In the case of the MH gap, we recommend that before that, we speak of the guides. Before you speak of guides, you do a diagnosis as to where am I going to give this training, to whom, what are their needs, exactly what is that they need of the guide, what things do they don't know to make it more like in sync with what people receive of what could be interesting or could be necessary for them now and the time of the application or the training as such. We do recommend that the groups be homogeneous. In other words, you don't mix, for example, specialized doctors of other areas with people whose knowledge of mental health or general health are a bit more basic, because these type of people, they generate a gap I give information that perhaps is very complex for average people, or give you information that is too basic for people that are requiring some further knowledge or far more advanced. So, to date, as far as I know, I have not seen any specific studies that discriminate according to my prior training level, how much learning have I had in respect of other areas in general. We do know that independent of the background that I have, you can achieve an increase in these diagnoses, in these knowledge, in the management, etc., etc. We have seen there that we can have an impact, but there's one thing that I particularly hits me, and that is that yes, we have shown that although these strategies do improve the knowledge of participants, in what where sees very little change is in the stigma. So, for example, if a person with strong stigma in respect to mental health, it's very difficult that only with intervention like this can I modify these belief system that the person already has about mental health in general. So that's why I'm insisting that even more than actually downloading the guides and to apply them, the idea is to use the strategy as a whole set. You have to go over above the technical knowledge you know about the illness. You that know about this illness. What ideas do you have about the person of the people who are sick like that? Well, we have them there because many a times there, that's where you start, is where we have to deconstruct before we tell you says what are the diagnosis criteria and the main symptoms.
Sí, perfecto. Imagino
Right,
que
perfectly.
está
Thank you very
chévere
much. I
porque el
imagine
tema de
that
estandarización
it is a
pues es
challenge
un
to
proceso que
standardize
demora
the
tiempo,
use of
Paula.
these tools,
Bien si lo
Dr.
usas
Paola,
como
whether if
profesional,
it's
¿no?
used a technician or a medical professional. Well, yes, precisely the idea of having this guide, in the case of these semi-structured tools, that they be structured so that they permit to reduce that viability of application to the models that they use them day in and day out when we're doing the trainings. Many a times we found that the people, because they want to do things right, they're actually too creative in the sense of changing the sense of the questions, and in mental health to us in one way or another can cause a great difference in between the information that I am capturing. So, for example, one of the things that we have done that we tell them in the training, where at least, and I'll tell you, gain the expertise, try to stick more to the script to actually stay there to the implementation of what the guy does or the interview, because only a person with a great experience or a lot of training can actually do certain variations and could do certain changes. But at the beginning, we do indicate that precisely at the beginning to avoid that variance, to follow the instructions or the ones we have there.
Gracias, doctora Paula.
Right.
En
Thank
cuanto
you, Dr. Paulo. Once I go
Arturo,
back to
creo que
Dr.
querías comentar
Arturo,
algo
and I
con
think that
respecto
you
a la
wanted to comment
intersectorial,
something
las otras
further about the
disciplinas, pero
intersectorial
aprovecho
ones,
porque
about
también
the health
había preguntas
studies,
y
but there's
quería
also a question that is addressed to you
entonces
from the audience
se cuestiona
where they
cómo este
question
programa
how this
FULECO
programs
se
of
articula con la
attachment
ruta
seeds is articulated with
integral de
the route,
atención en
the
salud
integral
materno-perinatal.
healthcare prenatal and postpartum care? That is an excellent question because the response is in no way whatsoever. And that is an interesting route. It actually dawned on me that I did mention Luis Gabriel is actually the case of the PI, the immunization broadened plan. This is something that is relatively works well in comparison with many other things, and it's an articulation there of early childhood and health, public health. So it seems to me that it's an example that we should take more into account so that all of these topics of care, social cycle care that should be followed in all of the learnings that we have had. In respect of the route, there's actually none at all. And there's something that in the future is going to shed us some light if we wanted to identify who were the people that need the most this pathway, that could be a mechanism of identifying that would be very valuable, that they need more with the mothers, the breastfeeding mothers. From there, we can begin to actually orient them there. For now, we're actually doing it through infantile or child development section, not even an early childhood. So the community sites, or there's a whole set of mechanisms that can help us to have that identification. So that's kind of the great opportunity. And to go more broad that we have there, I think that we, in that articulation, we should try to understand what did the immunization program PAE manage to achieve, what incentives did they manage to make it work so that they can have so successfully the upscale. And I think that there we have there that should be
Sí,
our
amplio y muy
path
específico
there.
a
Yes, a
estos
broad
aspectos
plan
de
of
reproducción
immunization
sexual
was the ones who follow there.
anteriormente,
It
que
is
son
one there
requeridos
definitively.
de
One would
escenarios
think
ideales
that
que
the ideal
el
scenario,
servicio de salud pudiera
the
rastrear
health
y coordinar los
service, we
esfuerzos,
could
como lo
track
ya hace
and coordinate the
exitosamente
efforts with what
para los
attachment seeds or
estudiantes
semillas
de
de
alto
apego
riesgo,
does,
que
so
es
that
como el
we
punto
do not have a
de acá
joint
donde la
follow-up. And
tecnología
that's
podría
where
materializar
you can
y
have this
ahora
decentralized, where you can
con más
materialize it.
reconocimiento
And
médico,
God willing, we could
medios
have with Medicine Sans
que pudieran
Frontières
generar
that we can
esa
have
capacidad local de
generated there of
innovación
this
para que los expertos de
ones
salud
that we
estén
have,
en
so that the
nuestro país y
socials
puedan continuar
we
haciendo
can
tanto
continue there, and not
trabajo
that one day
prevención
in this
pertinente en este
Doctors Without
proyecto
Borders we
de
can have
acuerdo
the
a
project
esa
and it all ends
bien
there. So there
importante.
is a very
Yo
important
sé que
challenge there.
estamos
I
pasados de
know that
tiempo y
we
que
are
nos
time
ayudaría
overdue. I'm going
bastante
to
para
ask you
iniciar
for some
que el doctor Lara
additional
en
minutes
México
because Dr.
queremos
Lara
compartir
from
una
Mexico wants to
experiencia
share
interesante con una
an
reunión
interesting
antes de irnos.
experience
Doctor
and
Lara,
to have some
en ese
reflections
sentido,
and
si
thought
me
for there. And
permite
Juliet, if actually we
el
can open
micrófono,
his
esperemos que esté
microphone.
conectado.
Let's hope that he's
Doctor
connected.
Lara,
El nombre del doctor Lara Luis Gabriel.
aparece como DR Lara.
It's Dr. Lara Luis Gabriel. There's yes, I don't see
Ya
it
se le
well.
retirará.
It's possible that maybe he has
Bueno,
left
muy
as
bien.
well.
Yo
Okay,
quería
so
comentar que
I just wanted to
varios
comment that there are other two.
ahora recordaba una herramienta que es
I
muy
was
útil.
remember this a very useful tool,
Un tool
which is the social
que es
needs
de
assessment
la
tool,
Asociación
which is
Americana
the
de
ones that
Médicos
we
de
have the
Familia, que es una
medical
plataforma
doctors,
para
the American Medical
fácilmente
Doctor Association,
identificar
which is a way that in the
identificar
doctor's visit, you can
estos
quickly
determinantes
identify
sociales de la
those
salud de la
decisive
persona
social factors
que
that could be
están influyendo de manera importante en la salud
influencing
física y
importantly
mental
in the physical
del
health and mental health
paciente.
of the
Y
patient.
toma no más de 3 minutos
And it takes no
realizarlo.
more than
Se
3
puede
minutes to
documentar
carry
y
it
es
out. You
como un
can
checklist de
document it.
acuerdo
And it's like a
a aspectos
checklist
sociales de la salud.
according to
Y
the
luego
social developments of health.
buscar
And it actually works
relaciones
as a
intersectoriales
triggering
entre resultados de la
mechanisms
historia clínica
that
con experiencias
intersectoral ones with clinical experience are actually very useful to
respuestas
begin to
en
work
otros sectores
in
y poder
responses to
coordinarlas.
these
Sí se
sectors in a
pueden coordinar las
coordinated
acciones
manner. Yes, we can
en la medida de las
coordinate the
limitaciones que
actions
el
through
sistema
the
nos puede
limitations
imponer.
that the system can
No sé, en
impose.
este momento quiero
I don't know, at this time I wish to kind of closing
la palabra a Natalia,
to give the mic to
luego María
Natalia,
Fernanda, de pronto
then
si
Maria
quiere
Fernanda.
comentar algo más
Perhaps if you want to comment anything more
complementar.
or to complement.
Lo que yo quisiera es agradecer por las otras
No, what I really want to thank is for all the other experiences that were shared. They were very interested, and there were times where we really have a lot of innovation and initiatives in the territories that are showing that they do work. And it's actually a call to experts in public policies for them to incorporate these social technologies in the institutional offer, because before it was one of the concerns of the assistants. How do we incorporate? What are the ties with the general offer of the territory? And well, the idea is that the social sector invests in this innovation so that governments can distribute a bit the benefits of these findings. So I just want to say thank you for that. Yes, Natalia, just how interested, just as you show it, it was shown by Arturo, how we have the importance of measuring the interventions, because as you well say, these results that speak by themselves are the ones that should get to decision makers of the key sectors so that they can design policies geared to mental health. Maria Fernanda, please.
Pues creo que igual en la misma
Well, I
línea
think that it was
de
going along the same line of Natalia to say thank you for the invitation, for giving us the possibility of MC to share these experiences that we have had and the learning experiences that we can share and we constantly have from the DMC.
Y pues nada, creo que esta también fue
And with
la
that, I think
oportunidad
that this
para
was the
hacer un
opportunity
homenaje a estos
to have a homage to all these agents, men and women that are really committed with their communities, that are there on the front line to try to support, to try to accompany, to try to bring closer the physical health as well as the mental health to their communities and to the people with a province like Choco and Marillas. They painted on their body and they come to think through to find better ways of diminish a bit the mental health gap. Well, thank you very much, Maria Fernanda. With this, I want to thank all guest speakers, and I'd like to give the mic to Janet for the closing. Thank you very much.
Muchísimas gracias a María
Thank
Fernanda,
you to Maria
Paola,
Fernanda, to
a Natalia
Paola,
y Arturo
to
por
Natalia and
acompañarnos.
Arturo for
Gracias
having
a todos
accompanied
los
us. Thank you very much for all the
participaron.
people
Gracias
from the
por
different places they connected.
María
Thank you for
Silvia,
the technical
a
team that actually
Juliet y a
accompanies
Juan
us,
Carlos.
Juliet
Gracias a los
and Juan
traductores
Carlos and so on.
Natalia, Luis
And then
Guido.
we have,
Por
and
supuesto,
to the
gracias
translator Luis Guiena, and of course, thank you very much
coordina esto,
to all the people there. We have Manuela Villar
mil gracias
and
y
myself.
esperamos
Thank you very
su
much. We
oportunidad.
wait you this in the next webinar. Please come.